Welcome to Vpod.ai. I'm your host, Mike, and sitting right here with me is our incredible expert, Susan.
Hi, everyone. It is so great to be here today.
You can sponsor this podcast for just $25. Your message will be featured across major platforms like Apple Podcasts, Amazon Music, Spotify, and more. If you're interested, visit Vpod.ai to get started today.
It really is a fantastic way to reach an audience.
Yeah, absolutely. So getting right into it, I want you to think about a standard machine for a second, like a car or a computer or even a city's electrical grid.
Right.
There is almost always an external power supply, right? You plug your laptop into the wall,
Yeah.
you pump gas into the car at the station. The engine itself, it doesn't feed itself.
No, it relies on that outside input.
Exactly.
Yeah.
But the human heart is this bizarre, almost miraculous paradox. It's a pump that literally has to feed itself with the very fuel it's pumping.
Yeah, it's wild when you really think about it.
Right? It beats around, what, 100,000 times a day?
Yeah.
And it is entirely relying on its own output to keep the whole operation running.
It really is the ultimate self-sustaining engine. But, that precise design feature is exactly what creates its greatest vulnerability.
How so?
Well, because it is completely dependent on a dedicated, uninterrupted loop of its own supply. If that loop gets compromised even a little bit, the whole system is in jeopardy.
Which begs the critical question, right? What happens when the supply lines feeding the power plant begin to fail from the inside out?
And that is exactly what we are getting into today.
Yes, today we are dismantling the mechanics of coronary artery disease, or CAD. It's actually the most common heart disease in the United States.
By a very wide margin, yes.
And we want to go beyond the basic plumbing analogies today. We're going to examine the actual cellular mechanics of this condition, uncover the hidden compounding risk factors, and really map out exactly how modern cardiology visualizes, stabilizes, and reverses this massive threat to your cardiovascular health.
It's a really empowering topic once you get past the initial fear of it.
Totally. So to start, we really have to look closely at the pipes themselves. We are talking about the coronary arteries, right? The main vessels wrapped around the exterior of the heart muscle.
Yes, the primary supply lines.
But atherosclerosis, the buildup of plaque, it isn't just sludge sticking to the inside of a pipe, is it?
Mm-hmm.
I mean, I think a lot of us have this mental image of like pouring warm bacon grease down a kitchen drain and it just clinging to the sides.
Oh, yeah, that is a very common misconception, and it's totally wrong.
Wait, really? It's not just gunk on the walls.
No, not at all. Atherosclerosis does not happen on the wall of the artery. It actually happens inside the wall itself.
Inside the wall, like built into it.
Exactly. So the innermost lining of your blood vessels is this incredibly delicate, single-cell thick layer. It's called the endothelium.
Okay, the endothelium.
Right. And when that tiny layer gets damaged, the fats and cholesterol in your blood, they actually slip underneath it. They get into the actual muscular wall of the artery itself.
Oh, wow. So they breach the perimeter, basically.
Spot on. And once they are in there, your immune system spots this intrusion and it freaks out. It sends white blood cells to clean it up. And suddenly, a massive inflammatory battle ensues right there inside the tissue.
Man, so it's less like a traffic jam on a road and more like a blister forming beneath the asphalt, like swelling inward and slowly choking off the flow of traffic.
Precisely. That is exactly what it looks like. And as that blister fills with fat and cholesterol and honestly dead immune cells.
Gross.
Yeah, a little bit. But it creates what we call the necrotic core of the plaque. And, what's fascinating here is an insight from Dr. Stephen Kopecky, who points out that this specific inflammatory process develops over an incredibly long period.
Decades, right?
Yes, literally decades. The body is so adept at compensating for the narrowing vessel that patients rarely have any idea this microscopic battle is raging until a critical threshold is crossed.
Okay, let's unpack this. If we return to the idea of the heart as a major city's central power plant, CAD is basically like the main underground supply pipelines developing these massive inward swelling structural defects.
Yes, structural being the key word there.
Right. And year by year, the physical diameter of the pipe shrinks. So the fuel trucks carrying the oxygen-rich blood, they get bottlenecked.
Exactly.
If those trucks can't get through, the power plant can't keep its own lights on, let alone generate the electricity to keep the rest of the city alive.
It creates a huge, dangerous deficit. I mean, the heart muscle is demanding a specific volume of oxygen to contract 100,000 times a day, but the narrowed arteries cap the supply. It literally can't get enough fuel.
So if this blister is growing silently for all these years, what actually causes that initial damage to the endothelium? Like, what allows the cholesterol to slip under the surface in the first place?
Yeah.
Let's look at the risk factors, starting with, I guess, the variables we can't really control.
Sure. Age is the universal constant here. I mean, decades of a beating heart means billions of mechanical pulses.
Just general wear and tear.
Exactly. It simply creates wear and tear on the endothelial lining. And we also have to factor in birth sex.
Right, because hormones play a role.
Huge role. Estrogen plays a really vital part in maintaining the flexibility and health of that inner arterial lining. Because of this, men generally face a higher risk earlier in life.
But that changes later, doesn't it?
It does. Women's risk profiles accelerate dramatically after menopause, exactly when that protective estrogen drops off.
Wow. And family history plays a massive role here as well, right? But the data points to very specific parameters.
Yeah.
It's not just about, oh, having an uncle who had a heart attack at 80.
Right. Getting a heart attack at 80 is almost standard for the human body. The severe genetic red flag is early onset.
How early are we talking?
We are looking at whether your father or brother developed heart disease before age 55 or your mother or sister before 65.
Oh, it is early.
Very. If that genetic predisposition is there, it essentially means the structural integrity of your arterial walls might be inherently more vulnerable to those microscopic tears we talked about.
Man, so the asphalt is just thinner to begin with.
That's a good way to look at it, which
Yeah.
is exactly why understanding the controllable risk factors becomes paramount. If genetics determine the thickness of your armor, your lifestyle determines how many arrows you are firing at it.
I love that analogy. So let's look at those arrows. We are all pretty familiar with the standard list, right?
Mhm.
Smoking introduces toxins directly to the endothelium.
Yes, direct chemical damage.
Right. And then obesity, a sedentary lifestyle, long-term stress, heavy alcohol, all of those create systemic strain. And of course, cholesterol.
Right, but specifically having a high concentration of the small, dense LDL particles.
The bad ones.
The bad ones, yeah. Those are the ones that easily penetrate the artery wall, and then combining that with too few HDL particles, the good ones, to transport them out.
Got it.
But I really want to highlight high blood pressure in this context because it directly links back to our blister analogy.
Oh, really? How so?
Well, uncontrolled blood pressure isn't just like a number on a chart. It is a physical, mechanical force.
Oh, right. It's pressure.
Exactly. It is the equivalent of blasting water through a garden hose at a pressure it just wasn't designed to handle.
Oh, wow.
Yeah, this sheer force physically rips micro tears into the endothelium. It creates the exact entry points for the LDL cholesterol to invade the arterial wall.
That physical mechanism makes complete sense.
Yeah.
The pressure creates the potholes, and the cholesterol just falls right in.
Spot on.
But here's where it gets really interesting. When you dive into the data, there are some highly unexpected triggers.
There really are.
I mean, we all know poor diet damages the heart, but the duration of sleep, the data indicates this U-shaped risk curve. We know sleeping too little is dangerous, but regularly sleeping too much, like over 9 hours a night.
Yeah, it's also linked to increased heart disease.
How does lying quietly in bed damage your arteries? And furthermore, the medical info notes that preeclampsia during pregnancy can cause heart issues decades later. How does an event from 30 years ago suddenly impact the heart today?
It sounds wild, I know. But if we connect this to the bigger picture, both of those surprises really come down to systemic vascular stress.
Wait, break that down for me. Start with the sleep.
With the sleep data, oversleeping isn't usually the direct cause of the damage itself. Rather, a physiological need to sleep 10 or 11 hours is frequently a biomarker for underlying metabolic dysfunction.
Oh, so the sleep is a symptom, not the cause.
Exactly. It points to hidden inflammation or maybe severe sleep apnea. It tells us the body is quietly fighting a systemic battle behind the scenes.
And the preeclampsia, how does that work?
Well, preeclampsia involves dangerous spikes in blood pressure and massive organ strain during pregnancy. Historically, it was just viewed as an isolated, temporary obstetric complication.
Like once the baby is born, you're fine.
Right, that was the old thinking. Today, cardiology recognizes it as an extreme cardiovascular stress test.
Wow, a stress test.
Yes. If a woman's vascular system failed to adapt to the massive physiological load of pregnancy, it essentially unmasks a baseline endothelial dysfunction. The pregnancy ends, sure, but that underlying infragility remains.
So she's basically walking around with thinner armor.
Exactly, leaving her arteries more susceptible to plaque formation years or even decades down the line.
That completely reframes how we should look at medical history. The body really just doesn't forget.
It keeps a score.
And I imagine these risks don't just operate in silos either. Like, if you have high blood pressure and high cholesterol, they must interact.
Oh, they absolutely compound. This interaction culminates in metabolic syndrome, which is this highly volatile cluster of conditions.
Which one specifically?
High blood pressure, elevated blood sugar, excess visceral belly fat, and abnormal triglycerides. When these occur together, you have chronic insulin resistance.
That sounds like a recipe for disaster.
It is. Your body is basically swimming in inflammatory cytokines that actively degrade the arterial walls. And that just rapidly accelerates the growth of that necrotic plaque core we were talking about.
And the research also highlights sleep apnea, which feeds right into that exact cycle, doesn't it?
Massively.
Because if you literally stop breathing dozens of times a night, your blood oxygen plummets, right? And then the sympathetic nervous system just panics.
Yeah, it dumps a huge amount of adrenaline to wake you up so you don't suffocate.
Which violently spikes your blood pressure while the heart is actively starved of oxygen. It's like a nightly torture test for the cardiovascular system.
A torture test is the perfect phrase for it.
There's also mention of elevated homocysteine. What exactly is that doing to the pipes?
So homocysteine is an amino acid that's just naturally produced by the body. Usually it's quickly broken down by B vitamins.
Okay.
But if levels become elevated, maybe due to genetics or dietary deficiency, it acts as a direct endothelial toxin.
A toxin, like it poisons the wall.
It basically chemically burns the inner lining of the blood vessels, which, as we know, further promotes the inflammatory immune response and causes more plaque buildup.
Man. If you're listening to this and doing the mental math on your own family history or, your sleep habits, it is so easy to feel a sense of dread.
Oh, for sure.
The roads are narrowing, the pressure is tearing up the asphalt, and the power plant is being starved. But the goal here isn't panic, right? It's awareness.
Exactly. Knowledge is power here.
So if this blister is growing silently for decades, when does the body actually realize the power plant is running out of fuel? How does the alarm actually sound?
The primary physiological alarm is a condition called angina. That's ischemic chest pain.
Ischemic, meaning a restriction of blood supply. Right. But it's not a sharp stabbing pain, is it?
No, usually not.
The classic description is a profound squeezing, right? Like a heavy pressure, or the sensation of someone standing directly on your sternum, slightly to the left.
Yes, exactly. When the heart muscle is forced to work without adequate oxygen, it switches to an anaerobic metabolism.
Like when you sprint and your legs burn.
Yes, which produces lactic acid. That buildup of acid in the heart tissue triggers the pain receptors.
Ah, that makes so much sense.
It typically happens during exertion or severe emotional stress. Times when the heart rate spikes, demanding a massive increase in blood flow that the rigid, narrowed arteries simply cannot accommodate anymore.
So it's basically screaming for more fuel and the pipe won't let it
Yeah.
through.
You will also see extreme fatigue and severe shortness of breath because the pump is literally failing to meet the body's overall demand.
Okay, so that explains stable angina where the pipe is just narrowed.
Yeah.
But we all know what a heart attack is. My question is, what actually triggers it in that specific moment? Like, what causes the pipe to suddenly go from a trickle to completely 100% blocked?
That right there is the crucial difference between stable plaque and vulnerable plaque.
Okay.
A myocardial infarction or a heart attack usually isn't caused by the plaque just slowly growing until it touches the other side of the artery.
Really? I always pictured it just slowly close and shut like a door.
A lot of people do, but no. It actually happens when the thin, fibrous cap covering that blister inside the artery wall suddenly ruptures.
Oh, wow. It just snaps?
Yes, it snaps open, exposing the necrotic core of fat and dead cells directly to the bloodstream.
Oh, and the blood instantly forms a clot over the rupture, just like it would if you cut your finger on a knife.
Exactly. But this clot forms inside a tiny, already narrowed tube.
Instantly shutting down the highway.
Instantly. The supply line drops to absolute zero. The muscle tissue downstream immediately begins to die.
Man, we've been taught the cinematic signs of this event forever, right? The crushing chest pain, clutching the left arm, sweating heavily.
A Hollywood heart attack, yeah.
But there's a massive diagnostic blind spot regarding gender, age, and underlying conditions like diabetes. The symptoms can be completely atypical.
This is such a critical public health issue. Women are far more likely to experience heart attacks where the pain doesn't localize in the chest at all.
So what does it feel like for them?
They might present with profound, unexplained nausea or severe heartburn, lightheadedness, or even just a brief, sharp pain in the jaw, neck, or upper back.
That is terrifying because it sounds like food poisoning or sleeping weird on your neck.
Exactly. And this is partly due to differences in how plaque is distributed in female anatomy. It often affects the smaller microvessels rather than just the major arteries.
And what about elderly patients or diabetics?
Well, the elderly and people with diabetes often suffer from neuropathy, which is nerve damage. And that can entirely mask the sensation of referred pain, leading to completely silent heart attacks.
Silent heart attacks.
Mm.
Unbelievable. I always think of the body's check engine light as this glowing, red, undeniable dashboard icon. But you're saying sometimes the alarm is just a subtle, weird rattle. It's indigestion that won't go away or a sudden ache in your jaw. How dangerous is the expectation of the Hollywood heart attack?
Honestly, it is lethal. Time is muscle.
Time is muscle.
Yes. Every single minute that artery remains blocked, millions of heart cells die. And they're replaced by non-contractile scar tissue. They do not grow back.
Wow.
If a patient ignores a tight jaw or severe shortness of breath because they aren't clutching their chest, they are missing the critical window for intervention.
What are the long-term consequences if they survive the initial event, but they delay treatment too long?
The structural integrity of the heart is permanently compromised. It leads to ventricular remodeling,
Right.
where the heart muscle becomes stiff, dilated, and weak, what we commonly call heart failure. The patient becomes permanently tethered to a failing pump.
That sounds miserable.
It is, and even more immediately life-threatening, the dead scar tissue disrupts the heart's delicate electrical pathways.
Oh, right, because it's an electrical system, too.
Exactly. This causes arrhythmias, which are chaotic electrical storms in the heart that can trigger sudden cardiac arrest without any warning at all.
So the stakes are absolute. If you feel any of those symptoms, even the subtle ones, you dial 911. You do not drive yourself. You do not wait to see if it passes.
Do not wait. Call 911 immediately.
Right. But let's look at how modern medicine actually fights back against this. Because if every minute means irreversible muscle death, the goal shouldn't be surviving the alarm. It should be catching the fire before it starts.
Absolutely.
How does a cardiologist actually see these blockages before the artery snaps shut?
The diagnostic toolkit is highly sophisticated nowadays. Beyond the initial physical exam and lipid blood panels, we rely heavily on imaging.
Okay, like what?
The electrocardiogram, or ECG, is standard. That captures the electrical footprint of the heart to spot any areas of poor conduction caused by ischemia. But to really see the muscle at work, we use an echocardiogram.
Which is essentially an ultrasound for the chest, right? Watching the heart pump in real time.
Yes. It allows a cardiologist to observe the wall motion of the heart. If a specific segment of the left ventricle is moving sluggishly compared to the rest, it's a clear indicator that the tissue there is starved of blood.
So you can literally see it struggling.
Exactly. And we pair this with stress tests, putting the patient on a treadmill or using medication to simulate exercise safely.
To force the issue.
Right, pushing the heart's oxygen demand to its limit to pinpoint exactly when the supply fails. And for a direct anatomical view, a cardiac CT scan can visually quantify the exact amount of calcified plaque in the arteries.
But the gold standard, the most direct tool, is the cardiac catheterization and angiogram. I'm always amazed by this procedure.
It's incredible.
They literally thread a tiny catheter from an artery in the wrist or groin all the way up the vascular tree directly into the coronary arteries of the heart, right?
Yes, guided by X-ray.
And they inject a radiopaque dye, and under that X-ray, they can watch the blood flow in real time. They can literally see the exact location, shape, and severity of that inward swelling blister.
It provides the definitive roadmap for us. And once that roadmap is clear, the interventions are highly effective.
So let's walk through those interventions. On the pharmaceutical side, we see three major players. Aspirin, which makes the blood platelets slippery so they won't form a massive clot if a plaque ruptures.
Right, keeping it from totally jamming.
Then we see beta blockers, which fundamentally alter the engine's mechanics by blocking adrenaline. That forces the heart to beat slower and with less force, which drastically reduces its oxygen demand.
Taking the pressure off the pump.
Exactly. And then there are statins. I think people assume statins just act like a little Pac-Man eating cholesterol in the blood, but the mechanism is much more clever than that.
Oh, it really is. Statins target the source. They go to the liver and inhibit a specific enzyme called HMG-CoA reductase.
Okay, and what does that enzyme do?
Well, the liver uses it to synthesize its own cholesterol. So by shutting down the factory, the liver is forced to pull existing LDL particles out of the bloodstream to meet its metabolic needs.
Oh, that's brilliant.
Yeah. It drastically lowers the overall concentration of cholesterol available to invade the arterial walls.
But if the blockage is already critical, drugs just aren't enough. The plumber actually has to go in.
Yes. Structural problems require structural solutions.
So you have angioplasty, where they inflate a specialized balloon inside the narrowing to physically smash the plaque outward against the vessel wall, right?
Yes. Followed by deploying a wire mesh stent.
A stent, right, to basically scaffold the artery open so it doesn't collapse again.
Exactly.
And if the calcification is too severe or if multiple vessels are involved, they perform a coronary artery bypass graft, or CABG.
A major procedure.
Yeah, and with this, they aren't even clearing the blockage, are they? They are physically bypassing it entirely.
That's right.
They harvest a healthy blood vessel, often the internal mammary artery from the chest wall or a vein from the leg, and they sew it into the aorta, grafting the other end into the coronary artery just past the blockage.
Building a detour.
They are building a brand new biological highway over the obstruction.
It is an extraordinary feat of engineering. The new graft seamlessly integrates into the heart's circulatory system, completely restoring the oxygen supply to the starving muscle tissue below.
So what does this all mean? If someone is listening right now and they or a loved one just got the angiogram, just got the official diagnosis of CAD, is their life fundamentally restricted? Are they just managing a slow, inevitable decline toward heart failure or a bypass?
This raises an important question about the nature of endothelial biology itself, and the definitive answer is no, a diagnosis is not a life sentence.
That's a relief to hear.
The endothelium is not static, it is a highly dynamic, responsive organ. While interventions like stents and bypasses fix the immediate mechanical plumbing issue, they do not cure the underlying disease process.
Right, because the inflammation is still there.
Exactly. True stabilization requires addressing the metabolic environment of the whole body.
Which goes back to patient empowerment, the lifestyle changes.
Exactly. When a patient overhauls their diet, eliminating the simple sugars and trans fats that drive inflammation, and focusing on whole foods that support endothelial function when they begin cardiovascular exercise and manage their visceral stress, they aren't just feeling better.
They are physically changing their arteries.
Yes, they are fundamentally changing the chemistry of the plaque.
Right, because we established earlier that it's the vulnerable, unstable plaque that causes the sudden heart attack.
Precisely. Aggressive lifestyle modification and lipid management literally pull the liquid fat out of that necrotic core.
It shrinks the blister.
It does. And the body reinforces the fibrous cap covering the plaque, making it thick, calcified, and incredibly stable. The vessel itself regains its elasticity. You can effectively freeze the disease in its tracks.
Transforming a ticking time bomb into just a manageable, stable, structural scar.
Exactly.
It's incredible. The body's capacity to heal if you simply stop throwing fuel on the inflammatory fire is unmatched.
It really is a resilient machine if you give it what it needs.
We have covered immense vital territory today. We started by dismantling the paradox of the self-feeding heart and explored the cellular mechanics of atherosclerosis, looking at how microscopic endothelial tears allow plaque to swell inward, literally suffocating the supply lines.
The blister in the wall.
Right, and we mapped the compounding risk factors, from the specific genetics of early onset disease to the hidden vascular stress tests of sleep apnea and preeclampsia. We broke down the critical ischemic cascade of a plaque rupture, highlighting the absolute necessity of recognizing atypical symptoms like sudden nausea or jaw pain.
Call 911, don't wait.
Always. And finally, we explored the incredible multifaceted interventions from liver enzyme inhibitors to biological highway bypasses that allow us to actually outmaneuver this disease.
Because understanding the true mechanics of how your cardiovascular system operates is the ultimate preventative medicine. Once you know how the machine works, you have the power to maintain it.
Absolutely. Yeah. But before we go, I want to leave you with one final provocative thought. While reviewing the medical documentation for this discussion, one specific biological marker kept coming up. High-sensitivity C-reactive protein, or HSCRP.
Oh, yes, a very important marker.
This is a protein your liver produces, and it floods your bloodstream whenever there is active inflammation anywhere in your body. The data shows that high levels of this systemic marker may be a direct, independent risk factor for coronary artery disease.
It really highlights the danger of chronic low-grade inflammation.
Exactly. And in modern medicine, we are highly conditioned to treat the body as a collection of isolated departments. You go to the orthopedist for a bad knee, the dentist for bleeding gums, the cardiologist for your heart.
Right, everything is separated.
But this protein reveals a radically different reality. If HSCRP is elevated by any systemic inflammation, could something as mundane as ignoring periodontitis like chronic inflammation in your gums secretly be accelerating the plaque buildup in your coronary arteries?
It's a huge shift in perspective.
It forces us to view the human body not as separate parts, but as one deeply interconnected reactive ecosystem. An immune battle in your mouth could be the exact stressor threatening the power plant in your chest. Just something to keep in mind the next time you think about skipping the dental floss.
Floss those teeth.
Thank you so much for joining us on this journey to understand the incredible, tireless pump keeping you alive right now. Keep questioning, keep learning, and we will see you next time.